Good day. This is Dr. Murphy with the Department of Anesthesia at the University of Kentucky. And this podcast is for the PGY2 second week rotation. And the topic is how to isolate the lung with a double lumen tube. The primary educational objective of this podcast is to present how-to and tips and tricks for double lumen tube placement. Your references are many, but the core reference for this podcast is Chapter 26 in Hensley's 5th edition, and I also recommend that you read Chapter 59 in Miller's textbook 7th edition, available on Clinical Key at the University of Kentucky. This cartoon from a textbook written by Dr. Benumof in 1995 shows the essential features of double lumen tubes, both left and right. And as you can see, and as you should have learned from a previous podcast, a double lumen tube has two cuffs, one for the trachea and one for the bronchus. This table from Miller's textbook shows you again how the 35 French double lumen tube is about the same size as a 8.5 internal diameter single lumen tube. And it also shows you how large double lumen tubes are, and explains why sometimes they are difficult to insert into patients. So, this podcast is supposed to help you learn how to do it, how to insert double lumen tubes. So first, let's start with the preoperative evaluation. I believe you need to decide whether or not the placement of the double lumen tube is elective or emergent. You should examine the patient to decide whether or not it's an easy airway or a difficult airway. You should review the chest X-ray or the CT scan. Regarding preoperative medication, it is my routine to use intravenous glycopyrrolate before all bronchoscopic procedures, including double lumen tube placement. Why? Anticholinergics are bronchodilators. You know they are antisilagogues, and that is how the experts do it. Dr. Campos is also a routine user of glycopyrrolate in all double lumen tube placements. The other author of the Miller textbook, Dr. Peter Slinger from Toronto, told me that he uses it in patients who have copious secretions. I would say that using glycopyrrolate before you have copious secretions would be preferable. In 2010, Dr. Slinger told me he was going to try to use glycopyrrolate more routinely when he went back to Toronto. This is the evidence that I use to support my assertion that experts use glycopyrrolate or other anticholinergics more routinely. It may not be the best study in the world, and it is really only a retrospective audit. However, the effect of an antimuscarinic appears to be beneficial, and it does appear that frequent thoracic anesthesiologists tend to use glycopyrrolate more frequently or liberally or routinely. So, back to the preoperative evaluation. A chest X-ray like this would alert you to a potential double lumen tube placement difficulties. this is an X-ray that Dr. Slinger frequently shows. So therefore, in addition to history and physical, you should review the imaging of the patient before attempting to place a double lumen tube. What size double lumen tube? You'd think that this would be an easy question to answer. I'm going to give you about 5 answers. First, in the textbook Anesthesia for Thoracic Surgery, 1995, it was recommended that the appropriate size of a double lumen tube is the one that results in a just seal volume for the endobronchial cuff that is greater than 1 mil but less than 3 mils. It was suggested that the tube be selected by the patient's height rather than their gender, and there were strong tendencies for short and tall individuals to receive small and large double lumen tubes, respectively, although the choice of size was moderately variable. Some of these are based on retrospective studies. So that's the first technique, 1995. In the year 2000, it was recommended in a different textbook and also in Miller's textbook that females less than 5'3" should get a 35 French tube. Females taller than 5'3" should get a 37 French tube. And as you can see, most males would qualify for a 41 French tube, as probably most males are more than 5'7". That's technique number 2 for selecting the tube size. The third technique, in 2003, it was recommended that the tube that is of a proper size should pass atraumatically, advance easily. The bronchial component should enter the intended bronchus without difficulty. There should be an air leak when the endobronchial cuff is fully deflated. And it was also recommended that tracheal width and bronchial width, as measured by chest x-ray or CT scan, could be used to select the double lumen tube. In practice, I have not run across anyone who is able to use the chest x-ray or CT and measure very much of the tracheal diameters. So the most practical part of this technique is that the tube be of a proper size that is inserted atraumatically, that it advances easily. Fourth technique. In 2005, Brodsky and Lemmer did a retrospective analysis of tracheal width and the size of the left double lumen tube that had been inserted. They concluded that tracheal width applied to a formula would result in a larger double lumen tube than recommended by using height and sex. These are some bar graphs from their publication, and the asterisk on each bar graph is said to be the recommended double lumen tube size based on sex and height guidelines. So in these bar graphs, which are all for males only, it reflects only the height of the male, and their findings were that the 39 and 41 double lumen tubes were successfully placed with a greater frequency than you would expect in short males, and that in males more than 170 centimeters in height, the most frequent tube size was a 41. Again, this is a retrospective study. In females, this similar kind of findings were presented, although I think that there's an error in this bar graph at the lower right hand corner showing that females more than 170 centimeters would be expected to have a 35 French double lumen tube. Nonetheless, you see that most often the 39 French double lumen tube was placed in females, at least if their height was 170 centimeters, or even if they were between 160 and 170 centimeters. So that is the fourth technique. The fifth technique for size selection of double lumen tubes. Dr. Campos, an acknowledged expert in thoracic anesthesia, again expressed the recommendation that the proper size is that which passes atraumatically, advances easily, and that the bronchial component passes into the intended bronchus without difficulty. He did, however, recommend measuring tracheal width for the posterior anterior chest X-ray to predict the left bronchial diameter and the correct double lumen tube size. So you're still at somewhat of a quandary as to what size to use. I have heard some people say that they only use the 35 French tube. That way it'll fit everyone. The only problem with that is that the smaller diameter bronchial component can be inserted quite deeply into the left side or the right side, depending on which tube you're using. And also you get a smaller lumen for ventilation and suctioning. So moving along, this is how I do it. Others may have variations on this. Others may disagree with some of the things that you're going to hear in the next few minutes. And I'll try to explain to you why I do the way I do it. So, first, I recommend that you read the accompanying literature of your double lumen tube. You'll most likely learn something about risks and benefits and how the manufacturer expects the double lumen tube to be used and managed. Next, all the bits and pieces of the double lumen tube should be accounted for, and the double lumen tube should be assembled. By that I mean the 15 millimeter connector should be inserted into the each lumen of the double lumen tube, and the double lumen tube adapter should be assembled so that you're not putting this all together at the time that you've just inserted the double lumen tube into the patient's lung, and during which time they are no longer being ventilated and have been apneic for some period of time. Third, you should take a 3 ml syringe and test the bronchial cuff, and a 10 ml syringe and test the tracheal cuff. You should decide if you're going to use a stylet. There's going to be a fair bit more about the stylet in later slides. So, now for an elective induction, a patient who's at low risk for aspiration. This may not be your esophagectomy patient. First, the patient should be in an optimum position. They should have optimum neuromuscular blockade for intubation, for facilitation of intubation. There should be an adequate depth of anesthesia. Most experts recommend the use of a Macintosh blade or a curved blade, and that's what I use. My interpretation of what I read is that the Macintosh blade is recommended because it is curved, and that it gives you more room in the mouth. I'm not sure if this is actually true or accurate. When you examine a double lumen tube, it turns out that it's actually a rather straight device and does not have the curve of a single lumen tube. Nonetheless, a Macintosh or curved blade is what's recommended. I would suggest that you consider using a tooth protector, or you may call it a tube protector if it's available. And the reason why I recommend this is because upon insertion of the double lumen tube, it is fairly common that the tracheal cuff passes over the teeth, either the incisors or perhaps the bicuspids or whatever teeth are on the right side of the upper jaw. And placing a double lumen tube with a damaged and leaking tracheal cuff is quite frustrating, because now you have to replace the double lumen tube. So you should have an alternative plan for insertion of a double lumen tube if it becomes more difficult than anticipated. Don't persist at doing something that is not working. Now, for a patient who is at high risk of aspiration or who is an emergency, you may choose to place a double lumen tube in a rapid sequence fashion. I suggest that you consider whether or not it's going to be easy or not, and that would dictate whether or not you place a single lumen tube first and then change it to a double lumen tube, perhaps after gastric suctioning, or you may try to place a double lumen tube with a fiber optic bronchoscope pre-inserted, or whether you would consider, as in any patient at high risk for aspiration, whether or not you do an awake fiber optic intubation. The insertion of double lumen tubes using an awake fiber optic approach has been described. However, I've never done it. And finally, there is the question of whether or not video laryngoscopy might be advisable or helpful in the case of a rapid sequence. However, I'm not aware of any studies that support this. So, some experts actually list rapid sequence intubation as a relative contraindication for double lumen tube placement. At the very least, it is recommended that you should have two persons involved with intubation if a rapid sequence and double lumen tube are going to be used, or you may just forget about it. So now let's review the actual textbook literature. Benumof recommends a Macintosh blade because of the tube curve, although, as I said in a previous slide, the PVC double lumen tube is actually rather straight compared to a single lumen tube, and I have never even tried to use a Miller blade in double lumen tube insertion. In his text there are many good descriptions, and they're very detailed, and if you can find a copy of his textbook, I would recommend that you read it and read the passage of the left-sided double lumen tube. As I mentioned earlier, some experts recommend using the fiber optic bronchoscope as a guide for the insertion of the double lumen tube. I have found only one author recommending leaving the stylet in the tube during insertion, and overall this is not a recommended step at all. So don't advance the double lumen tube with a stylet in place. I'm sure you would never think of doing that, but I'm just stating the obvious. So the depth of insertion. The typical depth of insertion for a double lumen tube in a 170 centimeter adult is 29 centimeters, and it increases or decreases about 1 centimeter for each 10 centimeters in height. It is not recommended that PVC tubes be inserted until resistance is felt. It used to be recommended that the double lumen tube constructed of red rubber material could be inserted until you felt resistance. And finally, typically, a fiber optic scope is used to determine the final position, and I make the comment that this may be true except at Stanford. And the reason why I say this is that I've heard Dr. Brodsky speak, and a few years ago he would make quite pointed comments about the lack of necessity of a bronchoscope for positioning double lumen tubes. And this publication in 2003 is what he uses to support the non-use of bronchoscopy, which would probably seem very retro to all anesthesia residents in training. However, you should know that double lumen tubes were invented well before fiber optic bronchoscopes, and that double lumen tubes can be placed using a stethoscope. So, more about how to do it and more about the stylet. I've heard that Dr. Benumof is most often quoted as recommending to leave the stylet in place until the tube is through the vocal cords. However, the actual text quote from Dr. Benumof's book is as shown on the slide and uses "if a less than optimal view of the larynx is anticipated, then the stylet that comes packaged with the tube is lubricated, inserted into the endobronchial, and in the example in the text, left lumen, and appropriately curved." So I would take from this that this is not a routine use of the stylet. Further, he describes that after the tube tip passes the larynx, and while anterior force on the laryngoscope is continued, the stylet, if used, is removed, and the tube is carefully rotated 90 degrees, and that would be 90 degrees counterclockwise. That is from 12 o'clock to 9 o'clock with the left-sided tube, so that the distal curve of the tube is now concave towards the appropriate side, or the left side in the case that we're talking about, and the proximal curve is now concave anteriorly to allow the endobronchial intubation of the appropriate side. What this is all about is trying to describe how proper insertion of a left-sided tube should result in the left-sided bronchial component being in the left side. It is possible to advance a left-sided tube into the right side. It doesn't work very well in that position. More about the stylet. The company recommends that the stylet be removed before use, indicating that its purpose is to maintain the tube in a proper shape while it's in storage. In other words, they call it a storage stylet. And to reiterate, it is not recommended to leave the stylet in the tube while inserting the double lumen tube into the patient. So personally, I assemble the double lumen tube and the 15mm connectors without the stylet in place. My rationale for that is that the double lumen tube is now ready to connect to a circuit. Think about it. You don't insert single lumen tubes without the 15mm connector, do you? If it is impossible to insert the double lumen tube directly, one option is to insert a single lumen tube and then exchange the single lumen tube over a lubricated Cook double lumen tube exchanger of the proper size. Or you can insert the Cook double lumen tube exchanger directly into the trachea and then guide the double lumen tube over it with the laryngoscope in place. You shouldn't insert the tube exchanger too deeply. That is, no more than 24 centimeters at the teeth or 10 centimeters below the vocal cords. Or you could insert a silicone lubricated fiber optic bronchoscope into the double lumen tube and guide the double lumen tube into the trachea with the fiber optic bronchoscope. I have done this. It is somewhat cumbersome, but I do believe that some anesthesiologists do this fairly routinely. Or you could use the storage stylet. I remove it from the tube. I straightened it. I then reinsert it into the tube, into the bronchial lumen, the same lumen that it was in the first place. Fashion it to emulate the radius of a curvature of a single lumen tube, more or less. And use this shaped tube to insert it in the glottis and then remove the storage stylet. Once you have, there's a little note just reminding you that the tracheal cuff is at pretty high risk of damage during intubation. Try to prevent damaging it. So what's new? Well, a few years ago, a double lumen tube stylet for the glide scope was invented. And this slide shows their instructions and warnings for its use. And as you can see, it's fairly obvious that this double lumen tube stylet for the glide scope is designed for right and left-sided tubes, and following the steps should aid in the insertion of a double lumen tube. There is a fair bit of clinical information here that can help you understand why double lumen tubes are difficult to advance, and it's in the second paragraph, or the paragraph one up from the bottom, and explains the 3 anatomical points where the double lumen tube may fail to advance. So that's what's new, but unfortunately they stopped making them in 2013. They may reintroduce this item in 2017, but it's no longer made. And there have been some publications from Canada on the use of a double lumen tube stylet, but they obviously acquired this reusable device before the manufacture was ceased. So also from the Canadian literature is a case report from, I believe, Africa, in fact. And it describes faster double lumen tube intubation with a video laryngoscope as compared to a standard laryngoscope. And I did my best to translate the article, which was in French only. And this is my translation, that they conclude it's the first randomized study comparing video laryngoscopy and direct laryngoscopy for the placement of double lumen tubes in thoracic surgery. And these authors found that video laryngoscopic visualization for intubation shortened the time to intubation compared with standard laryngoscopes. Yet to be accepted worldwide, but does show the potential utility for video laryngoscope. Oh, as a reminder, I just want to reiterate that the Cook double lumen tube exchange catheter, even though it has a soft purple tip, should not be inserted beyond 24 centimeters at the teeth to avoid laceration of the bronchus. So, this is an old cartoon showing how to insert a double lumen tube. And in fact, if you look at this double lumen tube, it is almost, it looks like it's a Robert Shaw tube and not a PVC tube. So this comes from Benumof, and I am telling you that despite proper technique, the left-sided double lumen tube does not always enter the correct side, and that you need to do tests of confirmation, such as inspection, palpation, auscultation, and finally bronchoscopy. Or, in reverse order, you may do bronchoscopy first. However, just because you inserted a double lumen tube that is called a left-sided double lumen tube, it will not always end up in the left side. If you read the legend for figure 9.12, you will get a flavor of how the tube should be manipulated in its insertion, and I believe that it by and large is pretty accurate. If you read letter C, the tube is inserted until either a moderate resistance to further passage is encountered, or the end of the common molding of the two lumens is at the teeth is a little bit old-fashioned, and probably describes the use of a Robert Shaw tube a little bit more than the PVC bronchocath tube, which has centimeter markings on it. The next statement, which says that both cuffs are then inflated and the lungs are ventilated, well, in fact, there's no need to inflate both cuffs to ventilate both lungs. You just need to inflate the tracheal cuff. However, the more you think about it and the more you do this in practice, the easier it will be to understand. So the insertion of a right-sided tube is a little bit more verbose. This study, authored by Dr. Campos and co-authored by Dr. Christopher Massa, a friend of mine who works at the VA here in Lexington at this time, describes how it is possible to insert a right-sided double lumen tube safely, and the proper procedures and steps to ensure that the right-sided tube is correctly positioned. This assumes, of course, that the patient has a favorable anatomy and that the right upper lobe bronchus is not too proximal or not coming off the trachea. This is a photograph of 3 brands of right-sided double lumen tubes. And I bring this slide to your attention to make you understand that, help you understand that there are more than one manufacturer for double lumen tubes. We use Mallinckrodt. Other brands are available. I have photographs of them in other presentations, and you have to know the design of your tube, your equipment, to use it effectively. This table comes from Miller, chapter 59, and is a summary of the indications for right-sided tube. So you may read a textbook somewhere that indicates that most of the time a left-sided tube is used, and it's because it's safer or easier or whatever. And it is all about the right upper lobe and it's being ventilated. So when you examine a right-sided double lumen tube, you'll see that it has a ventilation slot for the right upper lobe, and it must be positioned so that it is functional. You can review the anatomy and look at do bronchoscopies on patients, and you'll start to understand this. So here's an old cartoon from 1995, and kind of precedes bronchoscopy a little bit. Is a good thing to review so that you understand the correct positioning of a double lumen tube and its unilateral clamping. Perhaps when a bronchoscope is either not functioning properly or not available or whatever. I have highlighted 2 things on this slide, and obviously the clamping of the 1 lumen should result in the disappearance of breath sounds. Of course, if the bronchial cuff is not sealed, not inflated, you will not necessarily have the disappearance of breath sounds, and this is why in Benumof's other slide they indicate that the bronchial cuff should be inflated. In a few slides, I think I'll try to convince you that there's a proper way of inflating the bronchial cuff. So here's an experience item. The breathing bag has the expected compliance for 1 lung ventilation. So you have to have the experience and the knowledge of what a 2 lung compliance feels like compared to a 1 lung compliance. You can also use the ventilator and its airway pressures, which is what I do. This cartoon from Benumof 1995 is purely designed to help you understand the correct and incorrect positioning of a left-sided double lumen tube. On the diagram at the far left, it shows that the left double lumen tube could be inserted too far, and that the right lumen, or the tracheal lumen if you want to call it, is blocked, and therefore you're not ventilating the right lung. If you have the left bronchial lumen clamped and you're trying to inflate the right lung, if it's in too far and it's in this position, it won't work. If the double lumen tube is out too far, it's in the trachea, well, the left cuff can block the right lumen as you overinflate it. None of these things are going to happen if you use a bronchoscope. However, you may not have a bronchoscope. You never know. You should understand how double lumen tubes work. And finally, on the right side, the right diagram, the left double lumen tube could be inserted into the right side, and that would be a malposition, another malposition. I show this slide to emphasize margin of safety, and the left side of the picture shows the correct position, more or less. You could argue that if you can see the left endobronchial cuff from the trachea, maybe it is not perfectly positioned. The diagram says left endobronchial cuff just below tracheal carina, so you may see it, but it shouldn't be herniating, it shouldn't be bulging, it shouldn't be threatening to go into the trachea. A malposition, such as shown on the left, as shown on the right, with the double lumen tube insofar that the left upper lobe is blocked, is also a problem. However, you would be able to ventilate the right lung, but the left lung would not be properly ventilated. So while there is a greater margin of safety on the left side because of the length of the left main stem, it is possible that a tube that is small enough to advance all the way down to the left upper lobe would cause a problem. Now this is the just seal technique for the endobronchial cuff. I use a Salem sump tube rather than extension tubing. I learned this from Dr. Klafta at an ASA workshop. And I do this routinely in the operating room, and I believe that it allows you to inflate the bronchial cuff just enough to seal it so that the bronchial mucosa does not get ischemic as compared to inflating the bronchial cuff by feel. This diagram can be supplemented by the refresher course lecture in on the wiki, and I do this routinely, and if you do a double lumen tube insertion with me, I'll teach you step by step the way to use a Salem sump tube to detect the leakage of gas around an underinflated, incorrectly sealed bronchial cuff. So a few quick slides on bronchoscopy, and as you do bronchoscopy, either on real patients or on simulators on the internet, you'll learn the appearance of the trachea, the carina, the right and left main stem bronchi, the location of the right upper lobe, and the three bronchi which identify the right upper lobe, the three submental bronchi. So here's the carina is way off in the distance, and now it's up close, and the right upper lobe is at about 2 o'clock, and if you move your bronchoscope in and look a little bit right into the right upper lobe, it looks like this. This is a picture from Miller's 7th edition, and shows the view from the distal bronchial lumen in a well-positioned left double lumen tube. There are new landmarks to improve the positioning of the left bronchocath. And this article from the Canadian Journal and from Quebec, Canada, is a reference in Miller's textbook. And these images here are the best I have to show you that if you look down the bronchial lumen of a left-sided tube, when you get to the blue cuff, you should be able to see through the tube and see the carina. That is what figure 3 is showing you. I mentioned earlier that there were modifications to the bronchocath, and this is a photograph it's a slide or diagram of some changes that were made over the years to double lumen, the left-sided bronchocath. Well, this is the end of this podcast. I apologize for its length. It's something that you might want to run through more quickly a second time, perhaps. In any case, I look forward to working with you in the operating room and teaching you how I use double lumen tubes and achieve lung isolation. Thank you very much.